to the latest in the series of psychology talks. We've got today Neil Coulson, previously from IHU at the University of Nottingham, and since restructuring is now in the School of Medicine. And Neil has a long-standing career within health psychology. He's one of the old guard, not so much old, but he's one of the guard, and spent a good proportion of his career so far working in training-related issues. That's how I first got to know Neil, probably about 10 or 11 years ago now. And Neil's had various positions within the BPS, including chair of the DHP training committee, and was also chair of the Division of Health Psychology about 3 or 4 years ago. So Neil's here today to talk to us about the work that he's been doing over probably a decade or so now on the way people interact with forums and how they access and understand information that's available to them from health professionals and from their peers online. So, without further ado, Neil.
Not a good start if I trip and fall. I always like to keep standing upright during the talk. Okay, thanks ever so much to Marcus and Kathy for the invitation. What I want to do in this talk is introduce you to not only my work, but also a bit broader than that, and talk about some of the research that's happening in the sort of self-help and peer support online world. It spans many different areas, including psychology, counselling, communication studies, computer science. So there's lots of different pockets of literature, and it's a really interesting area to work in. And it's been something I've had a sort of long and lasting interest in over the last 10 years. And what I would like to do is introduce you and sort of illustrate and, I guess, showcase some of the issues, some of the potential advantages and disadvantages, some of the methodologies that we've used, and really to be quite honest about the state of the field, because it's evolving quite rapidly. But what I'd probably say from the outset is that a lot of what drives my research questions really come from the cold face, and by that I mean the people who are actually on the ground working in this particular area. So just to explain, I'm based in Nottingham at the School of Medicine, but within Nottingham we also have a charity called Self-Help Nottingham, which also has a national branch, Self-Help Connect UK, and they've been working for about 30 years in supporting people with long-term conditions, as well as people facing difficulties in their life. And they really are probably the national leaders in this sort of area. They have such a wealth of experience. And they've also been going on this journey with me over the last 10 years on how we try to understand the impact of the internet and living in a kind of digital connected world, and what that means for people helping each other when they're faced with long-term conditions. So their journey and my journey has really kind of been quite interwoven, which has been interesting and helpful, because we have regular meetings about once a month where we talk about the issues that they're facing on the cold face, and that often drives some of the research questions, which I then take back to university and may well become, say, a student project on an MSc Health Psychology, or I'll do myself, or might be the start of a PhD idea. So it's quite a kind of symbiotic relationship, and it helps me understand that it's not just about doing research in rooms and computers, but things that actually has a real-world application, and personally that's really important to me. So I just wanted to sort of start with sort of 3 quite obvious points, but just to kind of contextualise all this. And the first point is really to emphasise the fact that we are living in a changing environment now. Even when I started this 10 years ago, the way in which the internet had penetrated our life is really, we all know how much it's changed even in that sort of short window of time, particularly the way in which we are engaging with the internet through mobile phones and iPads and all the tablet computers, but also the continual increase in the number of individuals and households who are connected via broadband to the internet. And I guess the take-home message, and just to make absolutely clear, is more and more and more people are interacting in a way which could potentially foster communication and connection. That's something that I'll pick up on. So it's against this kind of backdrop of increasing internet use. The second point I just wanted to make, and we've known this for quite some while, but it's just to emphasise the point, is that when we talk to people just like ourselves, we find them to be believable and credible. And that's something that we see in various pockets of literature for many a year, but when we have a look at some of the sort of policy documents out there in the health world, we do see this emphasised as well. And it's really just, my interest is in people living with long-term conditions, and it's really just to recognise the fact that often in an interaction with a health professional, things might not always be equal. Patients may, for whatever reason, feel reluctant to really explore issues that are of concern to them. And if we can somehow tap into the power of people and our peers, then there is evidence, certainly in the face-to-face world, that that can really foster more adaptive coping, more adjustment to long-term conditions, more self-caring, however we want to define that. So against that kind of backdrop of the internet and also of the power of people, and finally, just to recognise that we're talking about individuals and not data points, the person living with a long-term condition, just to explain this, I like this diagram. This is sort of a very basic way of saying somebody living a life, it's peaks and troughs. You take the rough with the smooth, there's good bits, there's bad bits, there's relapses, there's remission. And so living with a long-term condition is bumpy, it's not a straightforward task. And throughout that, the yellow bars indicate where we might engage with the health services, going to the GPs, or going to the hospital to see specialists or consultants. And so we call these kind of episodic consultations. So a kind of bumpy road interspersed with fairly infrequent contact with health professionals. And if you think about it in the average year, really we have to manage ourselves with long-term conditions, every hour of every day, of every week, of every month in that year. But when you contrast it with the average number of hours you spend with a health professional, you can see quite clearly, a handful of hours with health professionals, the bulk of living with a long-term condition rests on your own shoulders. And so those three things are the kind of observations I would use just to kind of start us off on this talk. So the area I've been working in and what I wanted to consider in light of this greater access to the internet, greater use of it, is how this might impact on the way in which people living with long-term conditions could self-manage and support each other and learn and benefit from the experience of their peers. And so there's a whole variety of tools, and probably these are all fairly familiar to us. Things like Facebook has really dominated in the last 10 years. Discussion forums, Twitter, blogging, a whole host of social media tools are out there now. And if we have a look at it in the context of long-term conditions, we see the web is used as support tools. So it could be, say, self-assessment of symptoms. It could be interventions to help you cope with those particular symptoms, to manage them long term. It could simply just be information on websites. But many of these websites and tools have opportunities to connect with people, and they may employ some of these social media tools. And the one that I've been particularly interested in, because it's been the most prevalent, are the kind of bulletin boards and discussion forums. So much of what I'm going to talk about is very much located with that particular type of communication tool. So when we think about connecting with other people, living with a long-term condition in cyberspace, the term I like to use, although there are many we could choose from, are online peer support communities. So the concept of a community, a group of people. And there's several definitions out there, but this is as good as any from Günter Eisenbach, who in 2004 defined this as a group of individuals with similar or common health-related interests and predominantly non-professional backgrounds, so patients, health consumers, informal caregivers, who interact and communicate publicly through a computer communication network such as the internet, allowing social networks to build over a distance. And really what it's all about is peers with long-term conditions connecting in cyberspace. And that has been the kind of focus of my work. It's also worth just bearing in mind that there's different types of online communities that are out there, and we can pretty much contrast the kind of asynchronous with the synchronous. So by asynchronous, we're talking about your discussion forums that we're probably all familiar with, maybe from teaching platforms and Blackboard and Moodle, what have you, where you post a message, somebody might log in, reply to it, conversations might evolve over time. In contrast to chat rooms, where people are perhaps all physically logged in at the same time and having quite a fast-paced, interactive chat in sort of real time. By far the most common are the asynchronous tools, and that's what I've tended to focus on. So I have done a little bit of work on chat rooms. Many are moderated, not all. Many are moderated by patients who've, in a sense, become sort of leaders within communities. Some are moderated by health professionals, others it's a blend of both. If you're unsure as to what I'm kind of talking about, you may have heard of Big White Wall. Indeed, many people in the UK can get a referral through the GP, and the services of Big White Wall are paid for. And it's this idea of posting messages, responses, conversations evolving. This happens to be about mental health issues. Other ones I've worked with, Phoenix Rising, is an online discussion forum for people living with ME, CFS. And these forums can be pretty large if you haven't looked at them in the context of health. One of the largest that I've worked with has been just over 33,000 people. The smallest is about half a dozen people. On average, there are several hundred, typically several thousand people who will be registered users. Not all at the same time, because people dip in and out, but we're talking large numbers. So quite a contrast to your traditional face-to-face peer support group. We're talking about something quite different here. So that's just by way of a kind of brief background. And I just wanted now to consider some questions and I guess introduce you to this topic. First of all, why do people actually go online for support? Might seem a bit obvious, but not everybody does. So what are the reasons and what are the kind of triggers? And triggers is probably the best way to think about this. Invariably, there is a health crisis of sorts. It could be the perception of symptoms. It could be a diagnosis. It could be something, a family bereavement that has triggered something. It could even just be, dental problems, bleeding in your gums. It triggers you to perhaps go on and search Google. A whole different area about the power of Google, but that tends to be how many people who are finding it for themselves find these online support communities by Googling symptoms, conditions, and stumbling across these online support forums, of which there are many. Others may well be referred through charities such as Registered Health Nottingham, through GPs, through charities. Many of the big charities, like Diabetes UK, have online forums attached to their website. So they're becoming much more popular. But if we think about the actual nature of the communication that these communities are using, there's probably a number of unique characteristics which would explain their phenomenal rise in popularity. In the last 10 years, I've seen the numbers just absolutely mushroom. And these in blue boxes are the kind of consistent findings across my studies, but also across the literature more generally, that I've used patient interviews, both face-to-face and online, analysis of online discourse, what people are talking about online, as well as just having an awareness about the social media landscape and what's actually going on in the field. So accessibility, stands to reason. If you are connected to the internet, potentially 24/7, so for some conditions you may well be housebound, you can't do anything face-to-face, so this could be something which addresses those needs. It's convenient because you don't have to travel, there's no geography really involved. But importantly, issues such as anonymity are quite crucial in these particular communities. It's a bit of a double-edged sword, and I'll probably return to that later on. So on the one hand, it could protect you in terms of it's up to you what you reveal within these communities, and that might be seen to be something comforting and safe for individuals, but there is a downside, and I'll talk about that later on. And it's really up to you what you do and what you say. You don't have to reveal everything about yourself. You can reveal what you want in your own time and bit by bit. And so that level of control is really helpful. But often people also talk about the advantages, the uniqueness of this is there's so many people, so many different perspectives and opinions, and a really nice heterogeneous mix that you're bound to find someone who's just like you. And that seems to be quite helpful as well. So a number of unique characteristics there. But why do people, engage and actually spend time with these communities? This may well be a little bit small if you're at the back of the room. This is just, I just screen grabbed one bit of data from a study of people living with inflammatory bowel disease. This particular study has a number of fixed questions asking about reasons. These reasons were based on a lot of qualitative work, so we're fairly sure that they are appropriate. They're probably not all an exhaustive list, but if you can read any of the left-hand side, what we're seeing is quite high percentages, the highest one being to find others in a similar situation. And that seems to come out, regardless of the methodology, that people want to connect to other people. There is a desire and a need to find other people who are experiencing something just like themselves. And that might not be a given for many people. Perhaps it's embarrassing a condition, perhaps it's rare, perhaps they just don't want to talk about it publicly. Not to make light of it, but I remember one respondent said to me, I can talk about bowel movements to my heart's content online, but face to face it's a no-no. So people might find that the ability to connect is something quite powerful, quite helpful. As well as learning about what's happening to them, they also want to share. So there is this idea of giving back, sharing what one's learnt, and we'll see that throughout the talk, as well as learning and hopefully empowering oneself about the condition that you're living with. We see some convenience factors as well, which I've kind of mentioned. So that's just to kind of illustrate what you tend to find is this sharing online and receiving online tends to be the kind of two main drivers which people tend to talk about almost regardless of the particular condition. But there's a number of factors which will influence how people will interact online. I'm not going to go through all these in any depth, it's just to acknowledge some of the big issues. So there might be characteristics about the individuals, about the illness themselves, about the timeline, whether they're new to a community or whether they've been there for a while, whether they're more active in their engagement or more passive, leading to what's called lurking behaviour. So I just want to make some quick comments about each and illustrate some work that we've done on some of these issues. We've done some work looking at patient characteristics. Admittedly, it's not particularly well developed, and I think within the field it's not that developed either. It tends to be more of a consistent pattern, these kind of sociodemic profiles of your kind of white, female, well-educated, younger and employed tend to be the heavier users of these online support communities, as well as those of higher socioeconomic status. I think part of this probably reflects something to do with access, but I don't think it reflects all of it. I don't think it explains everything. I think we're just scratching the surface on patient characteristics, so I'm quite aware that there's more that I and others need to do in this particular area to work out who are the types of people that will engage with this online support and who will sustain that use, because people might just dip in and then dip out quite quickly. Illness characteristics. I've just put this slide up because I've not done a lot on it per se. It's more just to say what the field has written about it. And over time, things have changed quite dramatically. It used to be the case that it was your more stigmatised, embarrassing conditions or those with a very sort of unclear way forward were more present online. These days, because the internet and social media is so widespread, we tend to see almost every condition represented extensively online now. Obviously, for some of the rarer conditions, there's less presence, but the important thing is there is some presence now. We've also seen, probably in the last 5 to 8 years, a huge explosion on mental health related communities and web-based support tools. An area that particularly interests me is about the timeline and the journey into these communities. Very little has been written, so if we look elsewhere, there's some suggestion that one dips one's toe in, maybe looks and observes as a lurker to start with, and then maybe posts the odd message and becomes a bit more regular. They may well lead a group and become the elders. This kind of linear notion. I'm not entirely sure it works like that. I don't think we necessarily pass through all stages, but that's an area that I think we know very little about, and I think it's important to highlight those issues as well. But something I have been interested in is about the level of participation, and that links to the next slide about lurking. This idea that why some people become active within these communities, and by active I mean, taking the time to write messages, reply to messages, generate conversations, generate content, and actually upload it to the system, versus those who are perhaps much more passive and just read. So there's a whole sort of issue about the level of participation, and there's many possible reasons for this, I think, and certainly from our work we've seen some people say that, well, I put in because I want to get out, so this anticipated reciprocity. Others, a sense of efficacy, it makes them feel better, more confident in what they're doing by posting about their illness. Or it might be to try and establish a place of sort of legitimacy within a community. There's various models which we can tap into. A very easy and simple one, the uses and gratifications model. You do what you need to do in order to gratify a need. So if you want to find information and only information, you may just simply read and remain anonymous. But if you want to make more connections, you might be a bit more active. And that got us thinking, and when I say us, a question generated through Self-Help Nottingham is they were being asked by people, and some of their membership were saying, I'm not entirely sure that I want to actually type messages. I think I'm the sort of person that I much just prefer to observe and read. In our world, we call this lurking, a slightly negative, murky term there, but it just means this notion of reading without posting. And the question was, if somebody lurks, is that okay? Will they still benefit from the community? And if you'd asked us that 5-6 years ago, there probably wasn't much of an answer. Nowadays we've got more of a handle on that, and we've been doing some work, particularly in HIV and the infertility domains, looking at whether if you're somebody who simply chooses to read messages but doesn't ever really want to post messages, will you still benefit? It is a bit patchy and a bit bumpy and lumpy and mixed, the field, but I think the take-home message is, yes, you can still benefit, but there's something about actively taking part that you can accrue even more benefit. So, if possible, I think it is about active engagement, but if you're somebody who prefers passive engagement, that's fine, there's still a benefit to be had. I think this area is a little bit limited in a sense, because definitions within our fields are that lurking is simply reading but never posting. And certainly from my experience, there's people who tend to read but might post often, and might post not often, just 3 or 4 in any period of time. So I think there's some definitional problems that hinder the development of this particular question, but nevertheless it is an interesting one to ask and one that we're continuing with. So I'm just kind of going through giving little snapshots just to whet your appetite, I hope. So what do people actually talk about online? They've got online, they're there, we know a little bit about why they've maybe done that, but what do they actually talk about? And I'm summarising in this slide many different studies, including some of my own. I've done lots of different conditions, diabetes, all the usual cancers, HIV and AIDS, coronary heart disease, problem behaviours such as alcohol misuse. And there tends to be a common sort of pattern that comes out in terms of the content of this communication online. Typically, I'm sort of summarising here, discussions about symptoms, because these communities can catch people who are right from the start of their journey, so pre-diagnosis right through to I was diagnosed 30, 40 years ago, there's a lot of experience about symptoms, and so people often go on to discuss symptoms, interpret new symptoms, work out how to manage symptoms. A whole discussion area about diagnosis. Often for some conditions you pick up that diagnosis is not necessarily a straightforward thing. So for example, inflammatory bowel disease, there might be a bit of a journey before you get to that point. So for some conditions we see a lot about diagnosis in the run-up to it. but we also see the aftermath if it's a positive diagnosis for something, or even if it's no, it's not that. So Huntington's disease, for example, no, I came back negative. There's still the discussion of the sort of psychosocial impact. Huge amount on treatments. This is where I think peers are very, very keen to share ideas about what's worked for them, what's not worked for them, where to go for things, and this is something I'll pick up later on. Medications and also the emotional impact of all this. But it's not always about illness, it has to be said. Off-topic conversation is also allowed and welcomed. What I'm particularly interested in is, in addition to what they talk about, it's also about how they talk. And again, in blue, there are some things that we might be interested in from our particular background. I just want to pick up on the first two of those to showcase some of the work that we've done looking at how patients talk online. We've used a variety of analytical techniques, but just for the ease of presentation, I wanted to illustrate just two examples using content analysis. We've done a lot of this over the years where we've taken these messages, this user, patient or member generated content, and we've either top-down applied a kind of coding framework or generated something more iteratively bottom-up. This particular example, it was actually a PhD student of mine, Samira Malik, who analysed 3,500 messages, and they came from an infertility support community and different sub-boards that represented different parts of that journey. And we were interested in self-help mechanisms, and again, questions that are prompted by Self-Help Nottingham is, do you see the same things happening online that we see in our face-to-face groups? Because we don't know if we do. And one way that we tried to address that was by developing a kind of coding framework that tapped into self-help mechanisms. Probably wasn't the most detailed or best coding framework. It was a starting point, but what it does illustrate is what you can glean from reading messages in terms of support or empathy being pretty much up there. Just about 45.5% of those messages had something to do with support or empathy, sharing experience, providing information and advice. So you can begin to get a sense of what might be happening, these kind of active ingredients within groups. Another slide, which I'm sure Mark will have seen before, because I just love this slide because it's the very first time we tried this, and I always keep it in talks. Social support. We wanted to know, the extent to which within these communities people were supporting each other. What types of social support are being enacted online? And we used quite an old coding framework that took 5 main types of social support in bold, with various subcategories. We didn't use all of them, so I think it was about 22 that we ended up using. And we coded, I think it was about 1,600 messages about Huntington's disease according to 22 subcategories of social support by hand. So if you can feel the pain, the reason I have this slide is because this was a labour of love. It took a long while to do this, but it did offer us some interesting insights into what's going on, particularly informational support and emotional support being the highest two that we saw. What we tend to see on studies employing this type of methodology is that informational support, so it might be teaching you about a disease, giving you practical advice or referring you to an expert, is pretty common, as one perhaps might would expect, as well as the emotional side. And this could be understanding, encouragement, validation, you're doing okay. And what you tend to see on these methodologies is information and emotional support always being the highest two. Sometimes they switch around when whichever one is the highest, but they're always up there to start with, and it gives us a bit of an insight into what's going on. Esteem support, network support and tangible assistance tend to be the 3 types of social support, which are much lower down. Invariably it ends with tangible support, which is defined as practically doing something for someone, and given the online nature of the communication, maybe it's not it's not difficult to understand why that falls down to the bottom one. but we see esteem support and network support. So helping people feel that, paying them compliments, bolstering their sense of worth, as well as making them feel they're part of a community, that all is consistent and makes sense. So we've done a fair amount of this kind of text reduction type work where we've taken frameworks and coded messages and brought it down to this level. And we've also done a lot of work which has, in a sense, exploded it up the way. So a much richer analysis, trying to take a much more in-depth analysis of messages. So just continuing on this whirlwind tour, an obvious question, and one which certainly I get consistently from health professionals: should we be recommending this to our patients? What are the benefits, and are there any negatives? And those are the two small sections I want to just sort of finish on. So what are the benefits? Well, it's an interesting question to ask because it becomes a question about layers and levels of evidence. Certainly, if you go back to the work of Günter Eisenbach in 2004, he made a comment in the BMJ saying there really was a lack of robust evidence for the health benefits of peer-to-peer communities. And what he was basically talking about was the lack of randomised controlled trials. And that continues to be the case. There is a distinct lack, but there's many other types of designs that we have used that, if you take them together, are hinting very strongly that there is health benefits. But do we have the RCTs? Not yet in the physical domains. We have some limited work in the mental health arena. What we do have, and sorry, this will probably make your head bleed because it's not particularly clear font, is a lot of, sort of cross-sectional work. This was just a study by Phoenix Moore and myself, 340 HIV patients who used online communities. And we were adopting a sort of empowerment approach to try and ask the question, if you go online, what are the processes through which you might benefit or become empowered? So receiving information, finding positive meaning, receiving social support and helping others. And does this have any impact on active coping, self-care, self-efficacy, maladaptive coping and quality of life? I won't go through all the pathways, but basically the message that comes from these types of studies, albeit cross-sectional, is that engagement within online support communities or groups does tend to have an empowering effect on the individuals in a range of ways. They learn about their condition, they find some meaning from what's happening to them, they get support from people, and also they can help other people. And together that can play out in helping them adapt to their situation better, so better adaptive coping. It can reduce sort of maladaptive coping, and it can have some impact on quality of life. But we do need to test this out more longitudinally. There's a lot of work that has yet to be done. And I mentioned the lack of randomised controlled trials. This was just to give a nod to one of the only ones, I think there's probably a bit less than 5 really, that are pure peer-to-peer RCTs. And this is work from Griffiths in Australia looking at mental health. And again, the picture is one that online support groups and communities do seem to carry some benefits. But we've still got a long way to travel in terms of really getting that decent evidence base. At the moment, we're just trying to get funding to do some RCTs, but you know what it's like with the funding, head against the brick wall. So hopefully once we get something funded, we'll be able to test things out a bit more robustly. But I just wanted to finish on one final very important question, and this is one that I'm absolutely fascinated by. Are there negative consequences from all this? And the reason for asking this is because invariably, without hesitation, every conversation I've had with groups of health professionals, they've all just said, it's all a load of rubbish, they all just talk nonsense, let's not put patients into them. And actually need to look and see, well, what is the evidence? What does it tell us? What are the negatives? What are the positives? And if you have a look at the literature, the very old literature, what you tend to find is these 5 areas are argued to be the downside of online support communities. It's all rubbish. Patients and peers are just talking nonsense, so misinformation. Delayed feedback, it's addictive, it increases social isolation, and this thing called de-individuation.
Sorry, what's delayed feedback?
I'm just going to explain. Thank you for that prompt. So misinformation, this idea that patients are posting just factually incorrect nonsense, and obviously it's a concern to have, and it's a concern both to health professionals but also to patients. When we have a look at some of the literature, it tends to suggest actually it's not that big a problem. And if you just take, for example, Van Uden-Kraan done an analysis of messages posted to online communities and checked the accuracy of them. Esquivel done something very similar. And we're talking, a very, 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 very small number according to those types of papers. That doesn't quite cut it though, because within these online communities, anything that's wildly inaccurate could often be picked up by a moderator quite quickly and removed. And so doing this analysis of messages after the event might not actually tell you the whole story. But certainly in those, it's encouraging that it's maybe not this problem that health professionals fear. Delayed feedback, this idea that you go on for support because often you are at a pretty low point and time is crucial. You want support because you're perhaps feeling absolutely rubbish about something and nothing happens. And I guess the question is, how much of a problem is that and the extent of the problem? Well, it's a pretty serious problem if you're actually just about to, have a breakdown over something. Not to be flippant about it, but if you're absolutely at your lowest point and you've gone online and you need that support quickly and it doesn't come, you can imagine that the fallout from that could be quite severe. The extent to which it happened, this is a more interesting question because not all studies have even asked about these types of issues. You can do some analysis of when messages are posted and when responses come in, and that can be encouraging. But if somebody has an individual question or a post and it's maybe the next day, that could be too long in terms of their needs. Certainly in the inflammatory bowel disease work that I mentioned earlier, that did come out as a bit of a problem for some members. So I think there is more work to be done there. We also do, again with Self-Help Nottingham, training for moderators of these communities to try and intervene more quickly and to mobilise feedback so that people who need it get it. Even if it's in the middle of the night, there's somebody awake who could hopefully help you. There was a concern in the literature that the internet generally was addictive and it was all doom and gloom. Not been a lot in the online peer support literature in the context of health that suggests it's addictive, but there are some hints at it, which I'll come back to. And again, another more general internet one was, if everybody's online, we'll all just become very socially isolated. And again, in the work that Phoenix, Mo and myself are doing in HIV and AIDS, where we were having a look at whether, in fact, loneliness can be predicted by any of these sort of variables, and trying to build models and hypothesize relationships. And basically, the picture seems to be one that these online communities, far from making you feel more isolated, actually are making you feel more connected. Whether that's feeling connected, no longer alone, or reduced loneliness, various ways to sort of measure that particular sort of construct, they're all pointing in the same direction. Then this final one was de-individuation, this idea of people just lose oneself in these big groups, and the knock-on effect of that is that there are arguments, you don't play fair, you're online, we've all sent the RC email, or we've received one, so you know what I'm talking about. People say things online, do things online that you might not do face-to-face. Is this a problem online? Yes, it can be a problem online. Not many people have done work looking at the extent of it, but certainly from casual observation we can see that spats do happen, arguments do take place online. And so, returning to this question, are there negatives? Well, rather than just reading messages and trying to glean, we've done some work actually asking people directly about those negatives. And this was a survey of 295 infertility patients. Take-home messages, 170, so it's over half, reported experiencing disadvantages in that online community. And rather than being 5, there were 5 blue boxes, 14 distinct problems were identified. So for me that's quite powerful, because what it says is we do need to spend more time trying to pin down what are the issues, what are the negative things that could happen, and then trying to understand the impact of those negatives. So, for example, reading about negative experiences, reading about other people's pregnancies, inaccurate information, it's addictive, unhelpful replies, volume of messages, cliquishness, technical issues, hostile behaviour, social comparison, which I'll return to in a second, not being physically near someone, judgmental replies, lack of privacy, not getting a reply. So there's a whole range of different types of negatives. I mean, the numbers aren't massive, but it is important that 10% said reading about negative experiences was a negative. And we've certainly seen this in other studies. So just again, to return back to the inflammatory bowel disease work, to give you two quotes of what we mean by these reading ahead and how that can be difficult. It can cause you to panic about what could happen. You could read too much into the symptoms that other Crohn's patients suffer and worry this could happen to you too. There are a lot of horror stories. It's mainly really sick people who are online, too sick to be elsewhere. People who recover or are in remission stop posting, so we lose access to people who could add immense value by sharing how they recovered. So what we're getting from a number of studies where we're asking people directly is this notion that sometimes it's not helpful to read ahead about what might be happening. If you're new to a condition, you might not be ready yet to know that maybe surgery is a likely option, there may be fertility issues, it could be this, it could be that. It's quite daunting to process all that information when you're just starting out. And so this problem is starting to become a bit more serious. As when I'm asked, is it about inaccurate information? I've said, no, it's not about inaccurate information. It's maybe just about information that is either too soon to learn or might not apply to you. And bear in mind, you don't know who these people are. There's short profiles, very basic demographic information. There could be a whole host of reasons as to why what's happened to them won't happen to you. But within these online communities, social comparison processes are clearly taking place. And this is fine if we're looking up and aspiring to be that person who's recovered and learning from their success story. Or if we're looking down going, well, I'm not as bad as them, so I don't feel quite so bad, that's fine. But if you're looking up and saying, I'll never get to that point, or you're looking down and saying, oh, goodness me, I'm really going to suffer because this is going to happen to me because I'm just like that person. These sort of comparison processes could be quite damaging. So it's a bit of a double-edged sword, and it's something that I think personally is one of the more problematic features of these online communities. So that's just a little bit of an observation sort of there. Just to kind of draw that to a conclusion, as I know it's a bit of time, is what does this all mean in terms of practical implications? I'm very minded, okay, I've got a psychology hat on, but I'm very minded about the practical application of all this. And it certainly struck me over the years that there's a lot of apprehension on the part of both patients and professionals about these communities. But if they are seen to be helpful and the negatives aren't too bad, then it could be a useful sort of adjunct to traditional care. But we do need to clearly explore what the benefits are, particularly if we want to deploy resources into them. And we also need to know what the negatives are. But many charities and organisations have pushed ahead, and you'll see adverts on the telly trying to get people with long-term illnesses to join these communities and support each other. And I think the heart is in the right place, but we're still on a bit of catch-up. The challenges for researchers, I think, are largely in the design areas for me. I think we need to we really need to push ahead with the RCTs. We need to get that solid evidence. It's just not there. We have a lot of work which has been fed to commissioners, for example, that summarises self-help and peer support face-to-face. But when asked, should we be commissioning these online services, the evidence just doesn't add up. There's just not enough of it there. So we do need that better evidence, and we do need to draw that all together and synthesise it. In terms of the future research questions, even from this talk, you can see that there are dozens. So there's many MSc projects in there if you're doing an MSc. But for me, I think it's about longitudinal work, and it's about those RCT designs. I shall stop now before you start heckling and chopping tomatoes. It's time to go home. So thank you very much.
psychology that's drawn to these particular sort of outlets, catastrophizers, etc. Do you know what kind of cohort is attracted to this kind of method of sort of meeting? Because it's not everybody.
No, it's not.
Yeah, I like catastrophizers as a group. You know, there's a complete. Yeah, well, coming from a background in pain research, you know, we've got a few. But they're interesting. You know, you can get a distorted view of the normality of that population. Is the question. How atypical are they, and have you quantified whether they share some trait?
Just picking up on earlier comments, because I was whittling through that, the very honest answer is no, there's very little that's been done, but I absolutely agree with the question that you're asking. Beyond socio-demographic characteristics, there really is next to nothing that's actually taken any other type of construct that we might recognise in psychology says, or anything about, you know, take like personality type or something else. Typically, I mean, I haven't even seen it once people are in groups. There's such a lot of gaps. There's two that I'm thinking of. There's the following people up to see if they then choose to go online at some point, and even going in once groups are established and looking to see if there's anything they have in common. And there's really a lack of both, to be honest. So do I think there is something that they share in common? I suspect there will be. Do I think it's one thing? Probably not. I think it's going to be a more complex picture, but you're right, it's not for everybody. And it's not just about internet access either. So I don't have much of an answer to that, other than to say I agree that I don't think it's for everybody, and I don't know what the answers are.
So you emphasise one case that you could get some example of the scale of the difference. If this is only 10% of the chronically ill people, you've got a mountain to climb, but you also identified that there's something about that group. So it's just getting that figure.
Yeah, and surprisingly, there's very little. If people said to me, well, how many people go online for these online support communities? And actually, it's really, really difficult to guess, because some of the published work have said, you know, well, it could be, you know, up to 50% of a given population. Others, it's just 2 or 3%. It's really difficult. I know what I observed, but that's not a good enough answer in terms of these groups are, you know, tens of thousands of people. It's certainly much more popular than it was before, and I know also from colleagues in the self-help world that some of the face-to-face groups are closing down because people want to transfer to online to reach more people. We're also seeing a growing number of the silver surfers who are now online and are also living with multiple long-term conditions. They're also joining these forums. And if you actually have a look at the traditional forums versus like Facebook groups, the forums tend to be the older silver surfer, and the Facebook, you know, is the young people with, you know, the mobile phones who can dip in and out. So there's lots of things going on there, and I think it's a really interesting set of questions. I wish I had better answers for you.
I was just wondering whether or not you had any thoughts. I mean, you mentioned the silver surfers there, but one population who certainly use the internet probably more than most would be, you know, adolescent individuals who potentially are more susceptible to misinformation where it's present. They've not as much knowledge to make those kind of critical evaluations that you hope your older participants might have. But potentially are also more prone towards a number of those kind of other negative behaviours. Have you looked at all within any of the conditions that you're interested in, or do you think there are conditions where there needs to be particular concern about protecting young individuals with health complaints who may be online and may be really vulnerable to?
The answer to that is I have 98% steered away for adolescents. 2% I've dabbled last year in self-harm online that had quite a high number of teenagers. I've tended to, just as a personal preference, locate it within adult and older age groups, but I do know other colleagues who work more with younger people online. I think there are obviously some additional concerns about online safety, and on a kind of related point, I've done a lot of work in the last couple of years looking at susceptibility to online peer influence to do with alcohol, drugs and unsafe sex, and you know, it does play out. There is a susceptibility and there's a vulnerability issue there, but because I haven't done it in this, you know, not got a huge amount to say, but yeah, it would make sense. You know, I wouldn't disagree with that by any means.
In terms of disinformation, I was just wondering, how do you measure? I would have thought a bigger problem rather than people putting incorrect information onto a forum was just the fact that the people who are seeking information, many of whom maybe your kind of lurkers who you don't actually see messages from, are just picking up information that they think is relevant and actually isn't.
Yeah.
How is that? How do you measure that, and what impact do you think it has?
Well, I agree. I think that is. I perceive that to be the bigger problem. It's not that it's incorrect, it's just not applicable. And the challenge is because when you're online and you think somebody's just like you've made that assumption on the basis of very correct information and everything else, oh, you know, same age, background, this, that and the other, and then they'll tell you a story about X and somebody might then adopt that. And what they then do offline, either try that alternative medicine or do something, is really difficult to, you know, to determine. To be honest, I've not seen anything yet that's actually looked at the impact of that, to be honest. We've done some very, very basic work trying to look at how people make decisions about treatment and the role of these communities in terms of genetic testing. So, has been a member of a community helped you or hindered you in getting to that point? But I think it's when you're actually taking treatments and possibly medications and things that could be damaging to you because they're not applicable, that's a challenge. And to be honest, I haven't seen anything that's got a handle on that yet. But the question you're asking about, you know, how do you measure that? Yeah, absolutely, that is a challenge. And gosh, I haven't got an answer for anything today. But you'll see what I mean. This whole phenomenon raises so many more questions than it actually answers. And that's the thing that concerns me, is trying to make sure that these forums and communities and groups, that users understand that it's not a one-size-fits-all approach. So with Self-Help Nottingham, Self-Help Connect UK, we're trying to develop some sort of user guidelines to try and at least tell people that don't make decisions about your health and healthcare based solely on this. It's part of, you know, a suite of discussions with health professionals and this, that and the other. But invariably some people will make major decisions.
It might be a research question that's best answered through your healthcare professionals, because if your cohort do have even irregular meetings with a healthcare professional, that professional will have a good idea about what advice they're taking from online that is applicable and what isn't. So it could be something that's potentially recorded.
Yeah, assuming there's enough time for that patient to
yeah.
relay everything they've learned, and often it's a lot more subtle in those short snapshot things. But also, I will shut up in a second, is health professionals do have very mixed views. We've done some work with dentists, for example, where phobics who've been online, roughly about 50% of dentists said that's great that you're trying to deal with that, join an online group. Another 50% said that's absolute nonsense, why are you doing that? So you've also got to factor in, would the professional even entertain a discussion about the internet, let alone these online support communities that are, you know, hard to really kind of describe and quantify, and certainly not relay in a short space of time. What we do need to do is get some people as they join and find ways to follow them up and learn about everything that they do as a result of this engagement. And it's just trying to get the funding for that is challenging.
I'll just throw one thing in. Just wondering about the different kinds of condition and the extent to which online fora are interesting to people with different kinds of condition. And I was thinking about it in terms of problem space, and it strikes me, and I may be wrong, but it strikes me that if the problem space is relatively large, complex, and to some extent mysterious from the point of view of the patient, are they more likely to engage in a forum than someone with a much more simple and focused condition? Or is everybody at it?
Everybody is at it now, but the more ambiguous and complex ones were probably more represented and stigmatised and embarrassing and you know, those sorts of things early on.
Right.
But most people or most conditions have caught up in terms of having this kind of online community presence, would be probably my answer to that.
Anything else? Thank you, Neil.